of is important. There is many possible complications can occur. Like we can face the problem of difficult intubation, endocrinal management, prevention of atelectasis during the induction as well in post-operative period. There are many problems which requires a special management. Anesthesia for bariatric surgery is now a special division of the anesthesia specialty, and many young anesthetists have been interested and attracted to this. The webinar is also including obese patients, which is also important. All topics are interesting, and the webinar will update our knowledge regarding the anesthesia management in the obese patient. I welcome our invited guest speakers, Dr. Amla, Professor of Anesthesia in LTMMC College Hospital, Mumbai, Dr. Bhuvan Pandey, Senior Consultant, Sarkankaram Hospital, Delhi, Dr. Ujjwal Raj Dudhe, Senior Consultant in Hiran Nandani Hospital, Mumbai, and Dr. Sunil Pandey, Director of the Anesthesia and Critical Care. We pay our sincere gratitude to them for sparing time and to share their knowledge and experience. I am thankful to all chairpersons who will conduct the session very smoothly and will make it interactive. I am thankful to all Rsacp members and participants whose efforts will make this webinar great and successful. And I still again and again appreciate the efforts of Naveen, who is continuing always on top, the all CMEs conducting in time and means periodically timely, regularly I can say. So I thank you very much, Dr. Naveen, with all this regards to all, and long live Rsacp. Thank you very much.
Thank you very much, sir. I now invite our secretary, Dr. Naveen Malhotra, to say a few
words. Thank you, madam. Respected President Dr. S.P. Sharma, patrons, Dr. Tej Kaul, past President Dr. Avtar Singh, President-elect Dr. Indrani Hemant Kumar, and other office bearers of Rsacp, and especially the office bearers of Rsacp Mumbai branch. We started our Rsacp academic webinar series from Mumbai on the Doctor's Day, and today this is the second webinar being conducted by the Rsacp Mumbai branch. And I'm very happy that the academic programs under the banner of Rsacp are continuing, and I am very sure newer avenues, maybe something more than webinars, will soon start. Best wishes to the organizing committee, and I'm thankful to the speakers and chairpersons also for today's webinar. We should start the scientific proceedings. Over to you, Dr. Sonatale.
Thank you very much, sir. And now we begin our webinar for today, which is morbid obesity and anesthesia. The first topic, which is...
Madam, I am muting everybody. You unmute yourself. Okay. Please go ahead.
For our first session, I now invite Dr. Tej Kaul, a patron and senior member of Rsacp, and Dr. Nivedita Pani, who is Professor and Head, SCB Medical College, Cuttack, as chairperson for the first topic, which is anesthesia in patients with obstetric sleep apnea for non-bariatric surgery by Dr. Amla Kudal. Welcome, chairperson.
Good evening, madam. Can I start?
Yes, madam. Please, can you please introduce?
I am Professor Dr. Nivedita Pani, HOD, Department of Anesthesiology and Critical Care, SCB Medical College, Cuttack, Odisha. I am from the land of Lord Jagannath, and all my good wishes and good evening to all the Rsacp faculties and members and the governing council members and all the viewers. I feel very happy to have chaired this session, and which is such an important topic and anesthetic consideration for the morbid patient. Not only that, with OSA going for a non-bariatric surgery. Any morbid patient comes, how it is difficult for an anesthetist, that who gives that they know only, nobody else. I must thank you all, the organizers, and Dr. Indrani also for allowing me to be the chairperson. Now I I'm eager to listen to Dr. Amla Kudalkar, who is from the Shayan Hospital, Mumbai. So I request her to share her slide and to present her and to enlighten us with her knowledge. Thank you.
Hello everyone, and welcome to this webinar on obesity. I shall be dealing with anesthetic consideration in a morbidly obese patient for non-bariatric surgeries. I hope I am audible. Let's consider this a very simple day-to-day case. She is a 30-year-old patient for cholecystectomy with CBD exploration with BMI of 61 kg per meter square. You know? BMI is a surrogate marker for obesity. It is weight in kg divided by height in meter, that is squared. Anything above 30 is considered as obesity, and anything more than 40 is morbidly obese patient. A patient with BMI of 35 but having other associated comorbidities is also considered as morbid obese patient. And as the BMI increases, so all the comorbidities compound. So our patient falls somewhere here in the range of super obesity with a BMI of 61%. More important than the absolute value of BMI is important the distribution of fat. There are two types of distribution: android, where the fat is deposited inside and around the abdominal viscera, which is metabolically active, and it causes inflammation and is responsible for metabolic syndrome. Whereas in gynecoid type of obesity, it is the fat is deposited very safely in the subcutaneous fold of hip and thigh. And these are the various indices which will give you an idea whether the obesity is gynecoid type or android type. Obesity involves almost all the organs and systems of the body, to name all these. However, I want you to draw your attention to the metabolic syndrome. It is also causes metabolic syndrome, which is a nothing but a conglomerate of various conditions like central obesity, hypertension, insulin resistance, and dyslipidemia. The foremost importance to the anesthesiologist is the obstructive sleep apnea that sometimes accompany the obese patient. And what is that? It is a common disorder caused by repetitive narrowing or closure of pharyngeal airway during sleep, resulting in substantially reduced, that is hypopnea, or total closure or absent airflow despite ongoing breathing efforts. Now this is very important because in central apnea the efforts are not there, leading to a drop in oxygen saturation. Incidence of OSA in normal population is around 2 to 4%, but in obese patient it is as high as 40%, and in morbidly obese patient it skyrockets to 70%. And why it happens? This is because of the adipose tissue that gets deposited in the pharyngeal wall, and it causes the narrowing of the lumen. Not only that, the axis of the airway, it becomes, rather than lateral, it becomes anteroposterior, keeping all the pharyngeal dilator muscles at disadvantage, causing total closure of the airway. It also increases the pharyngeal wall compliance. So whenever negative pressure develops, the pharynx just collapses. And where does the obstruction takes place? Mostly in the retropalatal airway and retroglossal airway. And there starts this cycle of sleep apnea. Negative pressure, airway closes, no airflow occurs. There is retention of carbon dioxide and hypoxia, causing neural activation. Patient gets up and begins his normal ventilation. So this sleep and arousal cycle goes on, and there is fragmentation of the sleep, which causes ultimately obesity hypoventilation syndrome, where there is daytime hypoventilation also. So whenever the patient is awake, that time also he tends to sleep in the morning time, and there is retention of carbon dioxide. And these are the sequence of OA: interrupted sleep, impaired cognition, hypoxia, hypercarbia, pulmonary hypertension, and ultimately cor pulmonale. It also gives rise to macrovascular diseases. Now, how we are going to approach this patient? We have seen that it affects all the systems of the body. So take in detail history of all these systems. Not only that, how you have pack years for smokers, you have fat years for obese patient. How long the patient has been obese, that will tell you whether the changes are more than just if the where the patient fat only for 1 or 2 years. Any surgery in the past, any anesthetic received, any complication he has faced. Does she have any symptoms suggestive of GERD, level of activity and effort tolerance, any history suggestive of DVT, and most importantly, whether she is on any weight reducing drugs like fenfluramine, phentermine, or orlistat. Dr. Indrani most probably will deal with this in detail, but because it is important of this knowledge, because they do have anesthetic implications. In detail, ask about sleep history, whether the patient is able to lie down supine or what is her most favored position. Is she known to snore heavily? Has anybody observed apnea? Does the patient get sensation of choking and gets up with a start? Does the patient get up feeling unrefreshed, and does she have morning headaches? So detailed sleep history, and this is a questionnaire, stop bank questionnaire, which is nicely validated for OSA. And there are 8 points. Each point carries, each factor carries 1 point. And when it is total score is more than or equal to 5, it usually requires referral to the sleep physician. This is the airway assessment. Usually, whatever we do for other patients, same thing we have to do here. Remember that MPC, usually these patients will have higher MPC. Take the neck circumference. In this patient, it was 45 centimeters, and TM distance. Now, multiple studies have been done, and whenever each study will tell different values, but somehow more than 40 centimeters neck circumference usually indicates it is a predictor of difficult mask ventilation as well as difficult intubation. Similarly, another index, that is neck circumference to thyrometric distance ratio, that also predicts difficult intubation in obese patients. Now, what investigations are we going to do this in this patient? Now, she is only for CBD exploration. In addition to the routine investigation, blood chemistry that you do, it is very important to rule out whether she is suffering from any endocrine disorder. And the commonly associated endocrine disorders are hypothyroidism, pituitary diseases, and Cushing's. So, rule out by history and if required by investigations. Pulmonary function tests, 2D echo, nocturnal oximetry, polysomnography, and if required, cardiopulmonary exercise testing. X-ray test, typically scatter causing diaphragm to be pushed up. It looks like an expirated film, but it is because of the basal atelectasis. ECG will typically be small voltage because of the obesity. There may be LVH with or without strain, left axis deviation, arrhythmias. Atrial fibrillation is very common in these patients, and ST abnormalities. 2D echo again for increased LV mass, diastolic dysfunction, systolic dysfunction, and regional wall motion abnormality. And here we are very eager to know whether the patient is having pulmonary hypertension or not. Those patients who are suffering from hypoxia and hypercarbia over a long period are likely to develop pulmonary hypertension. PFTs will have typically restrictive pattern. The lung volumes are reduced, but flow rates are usually preserved. And mucus falls within the volume, causing peripheral airway closure, and there is reduced lung and thoracic wall compliance. Now, this is very important and it is very easy also, nocturnal oximetry. You can just keep observing the patient throughout the night when she is actually sleeping. A screening, can serve as a screening test based on clinical suspicion. And all this sawtooth pattern that you see here, it is because of intermittent hypoxia. So it doesn't remain, saturation doesn't remain at 100, but it keeps falling from time to time. And with this, you can calculate desaturation index of how many times the patient has faced the hypoxic events. Mesoendoscopy for diagnosing dynamic airway obstruction in patients with OSA. Sleep is induced with a sleeping dose of injection propofol, and a fiber optic endoscope is passed through the nose to identify the exact area of obstruction. In certain cases, this is practiced. And then the age-old polysomnography. It is a gold standard. It gives you an idea whether there is apnea, whether it is central or peripheral, and then the severity of apnea. This is the apnea hypopnea index. When it is normally, it is up to 5, it is considered as normal. And this is the degree of, AHI. Then in the second half of the study, you can titrate with the CPAP. CPAP is applied to the patient, and at what level all this pattern disappears, that is the CPAP level that you are supposed to keep perioperatively. So polysomnography is important in certain patients. This is a ABG. What I want you to notice is this is just sleep apnea syndrome, and this is the obesity hypoventilation syndrome. See, in this, the patient is not retaining CO2, but this is a patient who has CO2, carbon dioxide retention. So this is very important in the perioperative period, especially post-operatively. These patients can face respiratory obstruction. So how we are going to build up these patients for the operation? Give preoperative CPAP therapy. It helps to improve PaCO2 and reduce the PaO2 and reduces PaCO2 and reduces the sleep disordered breathing. OSA is typically called as sleep disordered breathing and improves the oxygen saturation. Improving outcomes in the obese patient, we can go actually the ERAS way. What is ERAS? It is enhanced recovery after surgery. It is a series of perioperative evidence-based interventions aimed at improving the outcome. And one thing is prehabilitation. How we have rehabilitation post-operatively, we have prehabilitation, and you try to improve the patient's condition in the preoperative period. Weight reduction, actually send a dietitian call and prescribe a fixed diet. Even if the weight is reduced in an elective case by 5% or so, it causes huge difference in the treatment of comorbidities that are associated. In addition to that, one can have chest physiotherapy and inspiratory muscle strengthening exercises, which will help the patient in the post-operative period. Are they at increased incidence or risk of aspiration? Well, they do have high IAP, intra-abdominal pressure. They may have hiatus hernia also. Therefore, very meticulously, you have to ask whether the patient is having any symptoms of GERD. But otherwise, there is no difference in the residual gastric volume and gastric emptying time in obese and lean patients. These patients can safely take 200 to 300 ml of clear fluid 2 hours prior with the same amount of gastric fluids at induction. If there is any doubt, or you can make it a practice that you can do a gastric ultrasound just prior to know the exact gastric volume. Mind you, it may be little technically difficult. Choice of anesthesia for this patient. I mean, regional does sound lucrative because it doesn't involve polypharmacy and doesn't involve any meddling with the airway. However, sometimes these patients, they are unable to lie down, and in that case, even if you have given regional anesthesia, the patient may not be comfortable. Plus, it also depends upon the level of surgery. If it is higher up in the abdomen, it is better to go with complete general anesthesia where ventilation can be controlled. Just remember that you have to deal with difficult airway. But it is, rather than doing it intraoperatively, it is better to do it electively. So in this patient, general anesthesia with CEA, combined epidural analgesia, proves prudent. Epidural catheterization also may be difficult because of obesity and pad of fat. So difficult landmarks which are obscured, long needles are needed, loss of resistance technique cannot be used. So it is better, always it is better to get the patient pre-operatively 1 or 2 days prior and scan the patient. Go for a posterior and anterior complex. If required, mark all these areas by marking ink. So it becomes easy the next time when you are actually doing. At the same sitting, you can also scan the patient for whatever IJV you want to take, or whatever suppose cricothyroid membrane. These patients, they may be difficult intubation, and it is better to locate the cricothyroid membrane, at least get an idea at what depth it is. Whatever all these procedures you can do electively 1 day prior. Obese patient should never be kept in supine position because of the in this patient, sedated, paralyzed, anesthetized patient, the abdominal viscera can press against the diaphragm, and diaphragm can literally crush the alveoli, causing profound atelectasis. Meticulous positioning of the patient is required, and always keep the patient in reverse Trendelenburg position with slight flexion at the hip. Never total straight, but slight flexion at the hip. This requires extra personnel who are well trained, and be very careful about protecting the pressure points. Why? Because it can cause not only nerve injuries but rhabdomyolysis in case of whenever there is hypotension or hypovolemia. So use liberally cotton and jelly pads. DVT prophylaxis we do give, but it must begin prior. Proper size stocking, sequential calf pumps, if they are available on rent also, so you can go for that. And in very high risk patient, one can go for IVC filters. So give meticulous attention to this. Pre-oxygenation should always be in 30 in head-eye position with tight fitting mask, so that all oxygen is taken by the patient, and add CPAP of 5 to 10 centimeters of water or whatever CPAP the patient is already on in the preoperative period, with PEEP of 5 to 10 centimeters of water when you are actually ventilating the patient. It is better to have two sources of oxygen. One is you are anyway breathing, holding the mask. But in addition, keep the nasal cannula, either regular or high flow nasal cannula, and see to it that end tidal oxygen concentration is 0.8 to 1, not percent. Pre-medication, will you give pre-medication on the night previous? Never. Never give sedation in the ward. Whenever you want to give sedation, it is always under your supervision, and preferably in the ICU, pre-op holding area, or in the operation theater. We avoid benzodiazepines in pre-medication because it represses the pharyngeal musculature tone and can produce apnea and airway closure. What we give is on table injection fentanyl, small dose, after all the monitors are in place, and then we start injection dexmedetomidine in a dose of 0.5 microgram per kg per hour with the patient in head-eye position. It does not cause respiratory depression. Antiemetic, we give dual injection dexamethasone, so 4 to 6 milligrams, and injection ondansetron. This is given. Certain terminologies you should know while dosing these patients. Ideal body weight, which is given by Broca's index. Then lean body weight, which is body weight minus the fat weight, usually taken as 20% more than the ideal body weight. Adjusted body weight and the total body weight, which is the actual weight of the patient. Whatever they say, whenever you are going to inject the drug into the body, say we take example of propofol. From the central compartment, it is going to go in the high vessel rich group, brain, where because of this high uptake, because it is lipophilic, there is going to be the patient is going to be anesthetized. But remember that within seconds, there is going to be redistribution of this propofol into the peripheral systems. So immediately you must start maintenance also. So this is just a rough guideline, dosing according to what body weight it is given. Never give except scoline. I think most of the drugs are given according to the lean body weight. But we do have excellent monitoring system in place, and therefore it is better to go for clinical endpoints or all these monitoring, like propofol you can give according to BIS, or muscle relaxant you can give according to TOF, and go for something objective endpoint. Should we do rapid sequence induction? Not really needed, just because the patient is obese, unless the patient is having symptoms of GERD, or if there is any predisposing conditions like diabetes, GI orders, or if it is emergency surgery, then it is necessary. Otherwise, there is no need to carry out rapid sequence induction. What we do for induction is propofol for its rapid induction and rapid offset and clear-headed recovery. But as I said, maintenance of anesthesia must start immediately after the induction dose, because to prevent accidental awareness. Succinylcholine for intubation, should we give? If the intubation, if the airway is likely to be difficult, you can give. But many people prefer not to give because of the, it is assumed that fasciculations increase the oxygen consumption and that they reduce wave apnea time. Rocuronium is ideal if Sugamadex is available, because if there is any doubt about the airway, it is always better to give suxamethonium. How to facilitate intubation? Let's say this patient who is lying supine, and because of this, because of the pad of the fat in the nuchal region and in the shoulder blades, there is the way airway is almost vertical, you can see, and it is difficult intubation in this position. So always ram the patient. Put pads of blankets and towels beneath her head and shoulder so that the tragus is at the level of external auditory meatus. Tragus is at the level of sternal notch. So this is the position which should be given, which can be given by using ready-made blocks, or if nothing is available, then help head elevated laryngoscope position. See that the tragus is at the level of the sternal notch. Keep your intubation difficult airway cart absolutely pit pat and by your side. Keep all the laryngoscopes with which you are comfortable, the intubating guides. But with the advent of video laryngoscope, it has become very easy, as it improves the visualization, reduces the intubating time, and increases the success rate. SGDs as a bailout procedure. Should we be using SGDs? Should we conduct the case on only SGDs? Well, there are many studies on that. Though they are very easy to insert, they do not give complete guarantee against aspiration, and there is always higher inflating pressure can cause leak. So this is again a way from Cochrane Library. This is by Tim Cook, so very authentic. So there is little literature currently exists to recommend the adoption of AGDs in obese patients. So when should we keep? Only very selective patients, like those who are for short surgeries or who can be kept in head-eye position and you have continuous access to patient's head. There must be a plan for tracheal intubation if it is required immediately. So plan A, B, C, everything should be in place. Another study which goes against the use of routine use of LMA in obese patients. So when they should be used, whenever they are used, it should be second generation HGDs because of their high ceiling pressure and because of the gastric drainage facility that is available. Should be used as a temporary device, as a bailout device, as a conduit for FOB guided intubation. I am coming to it later on. And in the end, for as Bailey's maneuver. Now this is, you can see the LMA through which this fiber optic bronchoscope over which this tube is threaded is being passed. So this can be used for intubating the trachea. How do we prevent hypoxia during intubation? Head-eye position, nasopharyngeal airway to open the airway when you are pre-oxygenating, IPPV with PEEP during the mask ventilation, and apneic ventilation using either the regular nasal cannula or by Thrive. You can give as much as 70 liters of oxygen, humidified oxygen through this, and it is, it is known to reduce the carbon dioxide also. So this you can keep, and it will give you an extended period of safe apnea. Phona, when you want to keep ready, make sure that you keep the long tracheostomy tube ready because of the increased distance from the skin to the trachea. How do we ventilate the obese patient? Well, lung protective ventilation. Even if the patient weighs 125, do not give according to the total body weight. The lungs are small. So tidal volume, which is around 6 to 8 ml per kg body weight of ideal body weight. Add a PEEP of 5 to 10 centimeters of water, and if there is need, you can go on increasing. Respiratory rate to target a eupapnic state. Always give head high position, so compliance is better. Ensure that there is adequate relaxation, so the airway pressures are not increased unnecessarily. Avoid high FiO2, never more than 80%, roughly 50 to 60%, to prevent reabsorption atelectasis, and recruitment from maneuvers from time to time. Either you give volume controlled or pressure controlled. Pressure controlled with where volume guarantee mode is better because it improves the oxygenation in these patients. Recruitment maneuvers we may have to use if the patient is not able to maintain saturation. Usually 40 centimeters of water pressure for 40 seconds or 50 centimeters for 10 seconds. Remember that as soon as you apply recruitment maneuvers, immediately add PEEP. So you open the alveoli and with PEEP you keep the airway open. So that is the logic behind it. So this I have already discussed. It has been seen that recruitment maneuvers along with PEEP gives better oxygenation. Maintenance oxygen and air. Avoid nitrous oxide if it is laparoscopic surgery. Small dose of fentanyl at induction, but afterwards we maintain the patient on dexmedetomidine. Inhalational anesthetics, desflurane, because of its low solubility in the fat, guided by end tidal concentration or MAC. TIVA, if you want to maintain on TIVA, you can do so by propofol infusion, which is guided by BIS, which is kept between 40 to 60. Muscle relaxant, short acting, again guided by TOF count. And analgesia, now this can be multimodal, and this thinking process has to start before in the preoperative period. Epidural analgesia, NSAIDs, paracetamol, various nerve block like abdominal surgery, we often give tab block, which is guided by USG. So all this has to be given. Monitoring, in addition to the routine monitoring, monitor the airway pressures, waveforms, respiratory gas monitoring, neuromuscular BIS, and central venous pressure if needed. Mind you, central venous pressure may show higher value in presence of increased intra-abdominal pressure. Now, fluids, I mean, there are two varieties, restrictive or liberal fluid administration. But whatever, with the liberal fluid administration, always it causes gut edema, it causes abdominal wall edema, the sutures are giving way. So see whether the patient is responsive or no. We can give pulse pressure variation or stroke volume variation or just pulse contour analysis. The simple thing, even if you don't have sophisticated monitors, and just one look at the pulse oximeter waveform, and if the waveform is wavy with each ventilation, that means that there is fluid deficit. In this patient, you can give small aliquots of fluid. Avoid total restriction of fluid can lead to acute tubular necrosis as well as rhabdomyolysis in presence of hypoventilation and dehydration. How do we reverse this patient? Reversal again is similar to maintenance. It should be guided by TOF, BIS, and MAC. The patient should be awake and responding at the end, extubated if it other criteria are met, not unless the TOF ratio is more than or equal to 0.9. Again, in head-high position, consider Bailey's maneuver in case of difficult airway or over airway exchange catheter or fiber optic bronchoscope. And again, immediately put the nasopharyngeal airway in situ. And if the patient was on CPAP prior, you can continue with the same. Now, this is what Bailey's maneuver is. That is, with tube in place, you insert LMA. In addition, once LMA is in position, remove the tube so that the airway continuity is maintained. And if you are worried about difficult airway, you are safe that the LMA is already in place. And this is the air exchange catheter which is placed inside the tube. Once the tube is removed, the airway exchange catheter, if required, you can thread the tube back again. Post-operative analgesia, yes, last few. Post-operative analgesia, multimodal. It should be opioid sparing, especially in those patients who are retaining CO2, because it will cause their respiratory center is not stimulated by retention of CO2, and these patients will suffer respiratory failure. So epidural local anesthetics. However, continuous infusion should be discouraged because it limits mobility. The one factor which goes against this is the patient has to be up and about as early as possible. And if you give local anesthetic by continuous infusion, this will prevent so. So go as peripherally as possible, give nerve blocks, port side infiltration, tab blocks, etc. And of course, paracetamol and NSAIDs. Post-operative complications, already delayed extubation, and I mean, you may never be able to extubate these patients, if they go in respiratory failure, respiratory complications, atelectasis, retention of secretions, etc. There is increased ICU stay and increased ventilator stay. DVT, a dreaded complication, and again it has to be treated or prevented rather on war footing. And rhabdomyolysis, so kidney failure in presence of hypotension and dehydration. So keep the kidneys flush. So this is in a nutshell all these factors that we have discussed so far over last half an hour: history, airway assessment, screening, look for associated OSA, prehabilitation, lack of no sedatives or sparing use of sedatives, maintain the head-eye position, RAM for intubation, short-acting drugs always monitored, extubation only at higher TOF ratio of 0.9 or more, and early mobilization. This knowledge will go in a high way in treating these patients better and better conduct of anesthesia. Thank you so much.
Thank you, Dr. Amla. As usual, a very clear and excellent lecture explaining everything and basic emphasis on preparedness. I think we should be prepared to deal with such situations and being in for sudden surprises. You can all type your questions in the chat box and we'll have a look at it at the end of the session. And for the next session on bariatric anesthesia, I now invite Dr. Avtar Singh, Senior Member and Past President of Rsacp, and Dr. Sarbari Swaikam, Head of the Department, Institute of Postgraduate Medical Education and Research, SSKM Hospital, Kolkata, as the chairperson. Over to Dr. Avtar Singh. Dr. Avtar Singh. Dr. Sarbari, can you please unmute yourself? Dr. Sarbari? Yes, ma'am.
Hello. Hello.
Madam, please unmute yourself.
Hello. Hello. Can you hear me?
Yes, sir. Yes, sir.
Can you hear me?
Yes, sir. Yes, sir.
Yeah. Dr. Sarvari, shall I go on with it?
Yes, sir, please.
Thank you so much. Thank you so much. Thank you, Dr. Indrani, for keeping me there as a chairperson. And thanks goes to Dr. Naveen and Dr. Sharma and whole of the GC members for ensuring that the webinars are going on very well and smoothly. Our next speaker is Dr. Bhuvan Pandey. He is a senior consultant at a very prestigious hospital, Sri Gangaram Hospital in Delhi. He's a part of the bariatric surgery team, which has a large volume of bariatric surgery cases to their credit. Over to Dr. Bhuvan Pandey, please. Hello.
Bhuvan Pandey.
Now, Bhuvan Pandey, please.
Hello. Hello.
Sir, you can begin, sir. Hello.
Hello.
Yes, Dr. Bhuvan.
Hello, sir. Kindly begin.
Just put it on the full screen view and you can begin.
Sir,
Hello.
can you please begin?
Hello.
Hello, Dr. Pandey. Sir, we can see your screen, sir. Just put it on full screen and begin.
Hello, am I audible, madam? Hello.
Yes, Dr. Bhuvan, you're audible. Please start.
Yes, sir.
Sir, we can see your screen. Please start, sir.
Yes, sir.
Well, thank you, organizers, for inviting me here for this webinar, Dr. Avtar and Dr. Sabri. Today, my topic is anesthetic considerations in obese patients, which is an important topic as whole world is suffering with the obesity now, and the cases are increasing day by day. As you can see, hello. Hello.
Dr. Bhuvan, please continue. You are audible.
Okay. Hello. As you can see, these obese patients are increasing day by day, overweight and obese patient. And since last 30 years, from 1975 to say 2016, there is 3 times increase of overweight patient and 2 times increase of obese patient in this globally. And so it is very important to know about the obese patients and their management. So I will be discussing this topic under following headings. First of all, obesity, which is an excessive accumulation of body fat in the body, which is around more than 25% of fat in the man, and if it is more than 35% of fat in the woman, it is known as obesity. And in another classification, if the BMI is more than 30 kilogram per meter square, it comes under the obesity criteria. In India, it is also a very severe problem because.
Sir, we cannot hear the audio well, sir. Can you?
Hello. Hello.
Sir, we can't hear the audio well, sir.
Is it better?
No, sir. Still.
Louder, little louder.
Hello.
Sir.
Hello.
Yes, now it's okay.
It is predicted that by 2040, overweight patients will be increased to 2 times and obese patient will increase to 3 times in India. And the problem is also worrisome for the Indian population, because the rate of increase of obese and overweight populations are much higher than the global population. It is also important to know about these patients because of the high morbidity in these patients. There are 3.9% of years of life lost in these patients, which is a measure of premature mortality, while 3.8% of disability adjusted life years are there in these populations, and this shows the morbidity load in the population. Coming to the history part, the obese patients is not a new type of entity, because it was present in the Paleolithic era as well. As you can see in these scriptures, it is old scriptures which is more than 12,000 years old and found somewhere in the Europe. There were some studies done, and this sculpture was found in the Austria, and this is a 65 mm tall sculpture, and the waist circumference is around 102 millimeter. So you can see how obese patients were also present at that time also. In India also, if you see the Charak Samhitas, which was available around 600 BC, he clearly mentioned if someone is pampering his belly and habit of sleeping at the daytime, sedentary lifestyle, less physical exercise, will suffer with many diseases and untimed death. Not only in Charak Samhita, it was also mentioned in the previous Indian ancient text, in which they have referred direct and indirect evidence of obesity, which was there at that time also. So coming back to obesity, BMI, as Madam has already mentioned, it is classified at 25 to 29.9 for overweight and obese class 1 is 30 to 34.9, and so on. And based on their BMI, ASA is classified and given the morbidity status. Like a class 1 obesity is class 2 ASA status, while class 3 is more than 40 BMI, which is referred as class 4 ASA status. And further, since in India, central obesity or apple-shaped obesity is more common in Indian population, and so and which is important for pro-inflammatory and other bioactive substances release, and which is more dangerous, and the comorbidity is much more, and the chances of complications are higher. So International Federation has decreased the BMI criteria for Indians or Asian patients, in which overweight patients comes in the range of 22.5 and 27.5, and so on. So others are more than 50 BMI is known as super obese, more than 60 BMI is super obese, and more than 70 is triple obese. As Madam has also already mentioned, waist circumference, waist hip ratio, which is all depicting the central obesity. And in another criteria, waist height ratio, which if it is 0.5 or more than that, it means the chances of cardiovascular comorbidities are very high and the complication may be more. But in all these patients, how to reduce weight? What are the chances and how to come up with the problem? First line is dietary modification, physical activity, counseling and behavior of the behavior modification, and lifestyle modification, which can decrease the weight up to a certain extent. But if it is not done, then the choice is bariatric surgery. Bariatric surgery is done when failed dietary and medical management, if there is metabolic syndrome, or if the BMI is more than 30 with comorbidity, or if the BMI is more than 35 without comorbidity, these patients are opted for surgical procedure. 4 or 5 procedures are done for bariatric surgery, but Roux-en-Y, gastric bypass, sleeve gastrectomy, these are accounting for more than 75% of cases. For anesthesiologists, associated comorbidities, optimization, airway, these all are important for us, as the complication rate in these overall complication rate is 10.6%, while the post-operative complication rate itself is 9.6%. In the pre-op evaluation, we apart from the routine test, we go for the polysomnography is if indicated, echocardiography, dobutamine stress echo if required. Though, as Madam has already mentioned, the obesity is related with all the comorbidity, all the systems are involved, but predominantly hypertension, diabetes, hypothyroid, ischemic heart disease, obesity, hypoventilation syndrome, OSA, and strokes are commonly found. So if there is a risk, then there is risk stratification score. So OS, MRS is the most commonly used stratification score, in which BMI, gender, age, hypertension, and other associated risk factors are taken. And if there are 2 to 3 points involved, the mortality is 1.1 to 1.5%. If it is 4 to 5 points, then the mortality rate is 2.54 to 3%. Coming to respiratory system, there is a restrictive pattern in these patients, and decrease of total lung capacity, vital capacity, and residual volume is significantly decreased. There is significantly decrease of FRC and expiratory reserve volume. These patients are rapidly desaturated, so proper oxygenation is required with ramp-up position. In these patients, atelectasis is also very common, as the FRC falls below the closing capacity. VQ mismatch, lung compliance is also decreased, and there is also increased airway resistance. So respiratory system is of major concern in these patients. Coming to these patients in which the obesity is there and plus respiratory component are there, these patients are prone to develop OSA. And if there is some suspicion of developing OSA, we have stop bang questionnaire to evaluate whether they are having OSA or not. We have few points like snoring, tiredness, observe the stop breathing or gasping during sleep, blood pressures, body mass index, age, neck circumference, and gender. So if there is intermediate or high risk, we go for the physician consultation for the OSA. And in polysomnography, if it is 15 to 30, it is moderate. And if apnea, hypopnea index is more than 30, it is very severe. And if they are severe, they are advised to go for CPAP application. But if somehow if they are not applying it properly, then it may lead to hypoxia, hypercarbia, and they are susceptible to sedatives, opioids, and anesthetic drugs. These are also cases of difficult intubation, and chances of liver dysfunction and right heart failure are very high. And overall, the complication is also increased. In obesity hypoventilation syndrome, in ABG, you can see the PCO2 level is high, PO2 is 70, serum bicarbonate is around more than 27, saturation is also low, and these patients require PFT, and this PSG is usually more than 15, that apnea hypopnea index. And these patients are more profound desaturation during sleep, that is ODI index is high, that is more than 10 around. Coming to airway, difficult intubation is much more common in these patients rather than difficult mask ventilation. And 37% airway issues are found during intubation, while 67% airway issues are noted in extubation. And most of these 28% patients are with OSA. Patients with Mallampati score of 3, male gender, patient with OSA or neck circumference more than 43 centimeter are predicted for difficult intubation. Coming to CVS, this though there is increased total blood volume and increased cardiac output, but there is impaired LV contractility and depressed ejection fraction, especially in patient with CHF. The prolonged hypertension and diastolic dysfunction, these all causes cardiovascular disease as a major cause of death in these obese patients. They are also due to venous stasis, pulmonary embolism, hypertension, CVA, commonly found hypertension are increasing the risk of this patient. There are n number of studies done to evaluate the risk in these patients. Obesity is the single most important predictor of type 2 diabetes, and in 70% of type 2 diabetes patients died due to cardiovascular diseases. These patients, because of pro-inflammatory regions, thrombogenesis increases the inflammatory syndrome of morbid obesity, increased fibrinogen, increased plasminogen activator, inhibitor, factor 7, and increased platelet aggregation will all lead to make the patient prone to development of DVT. These patients are hypercoagulable. Pneumoperitoneum, if it is given more than 14 mmHg and for more than 45 minutes, the chances of increased fibrinogen and D-dimer levels are altered. And all the other factors like smoking, oral contraceptives, and presence of pulmonary hypertension and OHS make the patient prone to development of severe DVT. In metabolic syndrome, as Madam has already mentioned, impaired glucose tolerance, atherogenic dyslipidemia, hypertension, increased waist circumference. These all increases the incidence of metabolic syndrome in BMI of 35 to 40 range, and the incidence is 15%, while in the BMI of 50. These all cases are of increased morbidity and mortality. Before the operation, patient should be monitored stopping alcohol 4 weeks prior to surgery will reduce the surgical site infection and wound disruption. If you give 2 weeks CPAP therapy, it decreases the ventilatory drive. If given for 4 to 6 weeks, it decreases the tongue volume, increases the pharyngeal stress, and make the airway simple. If it is applied for 3 to 6 months, it reduces the pulmonary hypertension. And in DVT prophylaxis, thromboembolic stockings, sequential alternating compressive devices, and chemoprophylaxis is given as per the BMI guidelines. Fasting is for more than 2 hours for clear fluids, as Madam has already mentioned. 300 ml up to 2 hours before the surgery can be given without any problem. And solids or non-human milk can be given 6 hours prior to surgery. Since there are many comorbidities, airways problem, increased perioperative complications, concern about drug dosing, adverse outcomes, and positioning. These are the area of concern for anesthesia. But in addition, the concern of avoiding hypoxia, maintaining airway, endotracheal tube migration, handling of patient, and proper table with which can bear a higher weight. Prevention of nerve injury, DVT prophylaxis, and other points are also be taken. Apart from the routine monitoring, we peripheral nerve stimulator, and in case of high-risk patients, cardiac monitoring is also advised. In most of the cases, if the girth of this biceps are more, then it's difficult to apply an IBP cuff, so we go for an invasive blood pressure monitoring. In pre-anesthesia medications, we give dexamethasone, ondansetron, and gastric stimulants, or antacids. Dexamethasone is important because it decreases the post-operative sore throat as well as the nausea vomiting in the post-op period. Difficult intubation in these patients are due to large tongue, short neck, increased neck circumference, high anterior larynx, and limited neck movement. And before intubation, we should have airway cart ready with non-depolarized, and in case of predicted difficult intubation, we should go for the awake fiber optic intubation and rapid sequence intubation in case of some suspicion. So, and rocuronium is the preferred drug as it doesn't cause any fasciculations. A ramp of pillow, lift head above the chest, and reverse Trendelenburg position is the position. But during this time, it is important to maintain the oxygenation. And if reverse Trendelenburg position and pre-oxygenation is not doing the proper work, then apply CPAP of 10 centimeter of H2O. Oxygen can be given during laryngoscopy with buccal oxygen of RAE tube can be supplemented. During anesthesia, use of short-acting drugs, smooth and rapid induction with hemodynamically stable, maintain the hemodynamic stability. These patients, these drugs should have a rapid recovery, which will decrease the post-operative complication, decrease hypoxemia, and it helps in actively participating and shifting the patient from operating table to the trolley, which will decrease the transfer-related problems. These drugs can be given, though it is very simple, but almost all the drugs are given as per the lean body mass. Desflurane and sevoflurane is the preferred anesthetic agent, which are minimally metabolized, better hemodynamic stability. They are rapidly recovered and less PONV in these patients. And there are many studies done in the literature which show the positive effect of desflurane. Xenon is another inhalation agent which is stable, but it is very, very expensive. And in very less centers, this is available. In the positioning, stabilize the patient, head stabilization, arm, lower arm, knee flexion, and pressure injury should be avoided. and padding or gel pad or bean pad, whatever is available, should be applied properly. At this back below the knee and proper mild flexion in the arm is required. Even after the positioning, this is difficult to maintain the ventilation in these patients because of excess fat externally and internally. It compresses the thoracic cavity, decreases the compliance of chest wall. In addition, when you create insufflate the abdomen cavity, increase of abdominal pressure, which shifts the cephalad movement of diaphragm. This will decrease the lung volume and increase the pulmonary blood volume. So how to improve in these patients? PCV and PEEP is given, or VCV, that is volume control ventilation of 6 to 10 ml per kg of ideal body weight plus PEEP of 5 to 10. Adjust respiratory rate according to ATCO2. But the preferred mode, what we are using is PCV-VG, which is important, and it gives the benefit of PCV and VCV both. Recruitment maneuvers are if you give 40 centimeter of H2O for 40 seconds or 55 centimeter H2O for 10 seconds. These two can be used to recruit the peripheral alveoli. We are using 40 centimeter and 40 seconds. In these patients, because of increased fat mass and decreased muscle mass and decreases body water, it is important to give the drug according to the lean body mass. And these are the commonly used relaxants: rocuronium, etrocurium, vecuronium, and we are using rocuronium or etrocurium as per the lean body mass. So not much fluid is given, though there are two thoughts. One is liberal fluid, but other is restricted. So we are giving 4 ml per kg per hour, or if SVV or PPV is available, according to that monitor we give. If there is some bleeding or some problem, we can start early colloid or blood products if required. All fluid should be warm to maintain the temperature. In the analgesia part, non-opioid are preferred, but during induction we give fentanyl also. NSAIDs, paracetamol, local infiltration. If patient is converted from laparoscopic to the open surgery, we give thoracic epidural analgesia for post-op pain relief. And in the post-op, some patients are requiring PCA, and which we are keeping in the demand mode only. As Madam has mentioned, dexmedetomidine, clonidine, and ketamine is given in these patients. Dexmedetomidine is given started at the induction, and this decreases the requirement of opioid or other analgesic drugs. As rhabdomyolysis is another dreaded complication, which is due to the prolonged surgical procedure, and toxins are released, and which causes the renal failure and death in these patients. Though the incidence is around more than 6%, and which is due to the long duration of surgery of 4 to 5 hours or more. And in these patients, this is more common in excessive weight patient, diabetes, and more than ASA 2 patients. In these patients, discolored urine, electrolyte alterations, muscle pain, swelling, and weakness is the complaint in this post-operative period. CPK is also increased in these patients, which is a diagnostic criteria for diagnosing this rhabdomyolysis. Reversal is important in these patients, as these patients should be extubated during reverse Trendelenburg position when the patient is fully awake and completely neuromuscular reversal is there of a TOF of more than 0.9. Recruitment maneuver should be given before the extubation. We can use Sugmadex or Doxapram 60 milligram to increase the respiratory drive. In the post-op, adequate analgesia, early mobilization, and we continue low molecular weight heparin after say 10 to 12 hours after the procedure. And in the post-op also, adequate hydration and vitamin supplements are required. Patients with more than 60 BMI, pulmonary comorbidity, and saturation, if not able to maintain more than 90, and male patients, they are requiring CPAP in the post-op period. And so to conclude, thorough evaluation in the pre-op, adequate counseling, anticipation and intervention of complications is required in to manage these patients successfully. Thank you.
Thank you, Dr. Pandey and the chairpersons. Madam, would you like to say something?
Yes, I want to give thanks to Dr. Bhuvanchand Pandey for his excellent talk and very lucid and elaborate. So these are really a very tough subject, tough to manage these type of patients pre-anesthetically, pre-operatively. So thank you very much, Dr. Pandey.
Thank you, chairpersons. Now I would like to invite for the next session, Dr. Anju Grewal, editor of GOSCP, and Dr. Vijaya Lakshmi, professor of anesthesia at Indira Gandhi Medical College and Research Institute, Pondicherry, to chair the session. Madam.
Good evening, everybody. I think Anju Grewal, madam, she's there. She's still stuck in the OT, I guess. So,
madam, that you can continue.
Yeah, shall we start, madam? Okay. So as we move on to the third session today, which is an interesting topic, the anesthesia for body contouring procedures, that is liposuction and abdominoplasty. To share his insights on this topic, I would like to invite our third speaker, Dr. Ujjwal Raj Dudedia. He's a senior consultant from the Hiranandani Hospital, Mumbai. He's got a large volume of experience in management of bariatric and body contouring surgeries. So body contouring surgeries have evolved over time in aspect of the surgical procedure as well as the anesthetic management. And it has raised from the concerns of health to beauty concerns also. So to start this topic, I would like to invite and hand over to the next speaker. Dr. Ujjwal Raj, sir, you can start off.
Thank you so much, madam. Am I audible to everyone?
Yes, sir, you are audible.
Thank you so much. At the outset, I would like to thank the Rsacp organization, Dr. Indrani madam, Dr. Naveen Malhotra sir, for allowing me to deliver this lecture. I would also like to thank my previous speakers who have made my job, both of them have made my job pretty simple, and I would be exclusively eliminating the obesity part from my job.
Ujjwal, slightly louder.
Still louder, madam?
Yeah.
Is this better?
Yeah, slightly.
Hello? This is better?
Yeah.
I would like to thank my previous speakers also for reducing my job and making it more simple. I would exclusively eliminating the obesity part of management. I bring greetings for the Diwali and the Happy New Year from the Institute, Dr. L.H. Hiranandani Hospital where I work. As I go through my presentation, I'll be taking you to the body contouring procedures. What exactly do we have in the a la carte? What all procedures we do? What are the different techniques we use to do these procedures? And then comes the anesthesia management pertaining to these procedures, which constitutes pre-op evaluation, intra-op concerns, what techniques we use for anesthesia and what all we need to monitor. How do you calculate the fluid requirement and how do you transfuse them and how do you assess the blood loss? What are the complications you should be ready? How do you provide post-op analgesia? And in the end, I will discuss what exactly we do. And throughout the proceedings, I will not be taking consideration of the obesity part because most of them have been enumerated by the previous speakers. So why is body contouring required? It is primarily required for two reasons. One is cosmetic, another is the aesthetic. Cosmetics primarily for fat reduction, augmentations of various body parts and curves, and lifts for the drooping and age-related process. For aesthetic procedures, it is primarily after a massive weight loss, preferably or probably due to bariatric, fasting, keto diet, etc., etc. And after pregnancy. So primarily they are liposuction and various body contouring procedures, various plasties and various pexes. This is the list. Primarily surgery and abdominoplasty, lower body lift, thigh lift, mastopexy, torsoplasty, gluteus contour enhancement, brachioplasty, face and neck forehead lift, liposuction. Primarily I will be discussing in the pretext of abdominoplasty and liposuctions. Coming on to liposuction. It can be divided into 3 types, which is based on the injected used to perform the procedure, based on the volume of aspirate during the suction, and various techniques to perform the suction procedures. So based on the injected, it is dry, wet, super wet, and tumescent. Based on volume of aspirate, it is small volume, large volume liposuction, medium volume liposuction, and large volume liposuction. And based on the techniques or various gadgets, it is the syringe assisted liposuction, the laser assisted liposuction, the sound wave or the ultrasound wave assisted liposuction, or vacuum assisted or power assisted liposuction. When we talk about dry technique, it is that there is no solution is injected. It is primarily done for small lipomas and small lesions. The blood loss is 20 to 45% of the aspirate volume. Wet technique, a 200 to 300 ml of solution is injected in the desired area, and then the suction is done. Blood loss is reduced as compared to the dry technique, and it is 4 to 25% of the aspirate volume. Super wet is a technique where equal volume of solution is injected into the body as the aspirate is to be required. Blood loss reduces drastically to basically 1% of the aspirate volume. Tumescent is one step above the super wet one, where 3 to 4 ml solution is injected per ml of aspirate, and blood loss again is reduced to 1% of the aspirate volume. So as you gather, the more fluid you inject into the body, the blood loss reduces. The more fluid you inject, the aspirate volume increases. So there comes the small volume aspirate or small volume liposuction, where up to 1 liter is aspirated, medium, which is less than 4 liters, and large volume liposuction, which is more than 4 liters. As the volume of liposuction increases, the complication rate increases. What are the other types of liposuction? This is suction assisted liposuction, where a small volume can be suctioned to remove the fat from the superficial layers, and a technique which needs to be designed to prevent dimpling and hyperpigmentation. So the cannula is inserted very gently into the layers, and this is the primary technique used for six-pack abs by most of the people. Then you have the ultrasound assisted lipectomy, which has advantages over areas which has high fibrous tissue such as back, chest, and upper flank, and also used in the treatment of gynecomastia. But important side effect is the thermal injury or the subdermal tissue, thermal injury to the subdermal tissue of the exothermic energy of the ultrasound. Laser assisted, it is similar to what is ultrasound assisted, and again skin burns and thermal injury plus local infection are the predominant side effects, but can be done with smaller incisions. And power assisted, where power assisted of external vacuum is utilized. This is the commonest procedure used and can remove good amount, large volume tissue and in the densely fibrous area also, and reduces the operator fatigue. These are the 3 machines used. The extreme left is the laser one, the middle one is the ultrasound one, and the third one is the power machine. What are the areas which is amenable to liposuction? These 2 diagrams depict all over the body you can have the liposuctions done. There are certain non-cosmetic indications also for liposuctions, predominantly lipoma, gynecomastia, pseudogynecomastia, axillary hyperhidrosis, buffalo hump, undermining flaps, lymphedema after the axillary clearance, insulin-induced lipodystrophy. So coming on to the most commonest procedure, the tumescent liposuction, wherein you inject 3 to 4 ml of aspirate in the solution. 3 to 4 ml per ml aspirate of solution is injected into the areas where the liposuction is to be performed. Initially 20 gauge spinal needle is used, and subsequently as the fluid gets in, 16 to 18 gauge of infiltrating cannula can be used. Use of peristaltic pump can be taken for help to inject this fluid inside the area. Maximum flow rate is 100 ml per minute, which is tolerated. The surgeon is supposed to wait for at least 15 minutes to have the Turgor effect on the tissue. And the clear signal to start the procedure is the blanching. This is how blanching of the skin reduces. Now, for tumescent liposuction, important is the fluid used, the typical tumescent anesthetic fluid, which consists of lidocaine, which is the local anesthetic, epinephrine, which acts as a vasoconstrictor, soda bicarb, which alters the pH and reduces many complications, and the primarily base fluid, which can be normal saline or ringal lactate. So there were two scientists, Klein, who was the one who first started the tumescent procedure with normal saline, and he started using lidocaine 50 ml 1% in 1000 liter or 1000 ml of isotonic saline with 1 ml 1 in 1000 epinephrine with addition of 12.5 ml of 8.4% soda bicarb. And Hunstead, instead of isotonic saline, used ringal lactate, and he used 50 ml of lidocaine, which was 1%, and 1 ml adrenaline, which is 1 in 1000. What is the role of the drugs and the fluid in this? Normal saline, it is the primary dissolute fluid which is used to fill the area and dissect the adipose tissue. Primary drawback is because of its acidic pH, it causes burning sensation on injection. Soda bicarb, when it added in the amount of 1 milliequivalent per liter, reduces the pain for normal saline, and in the concentration of 1 milliequivalent per 10 ml of local anesthetic solution, it reduces the ionization of local anesthetics for better penetration to the nerve. Adrenaline, we all know, causes vasoconstriction, that causes delayed absorption of local anesthetic solution, causes reduction in the blood supply of that area, which causes reduced bleeding, but has a problem that intraoperatively it can give rise to hypertension, bradycardia, arrhythmias, and other issues if it is absorbed pretty rapidly or goes intravascular. So maximum dose which is to be used is 0.07 milligram per kg. Steroid can be added to the solution, which gives the anti-inflammatory effect, and antifibrinolytic agents reduce the post-operative bleeding after the liposuction procedure. Coming on to the basic, the local anesthetic in the tumescent anesthesia. Lignocaine is the drug of choice used by majority of the surgeons, and it can be taken. The American Society suggests that maximum up to 55 milligram per kg of lignocaine can be used. Now, this is far, far away beyond what we recommend in our anesthesia textbook as with adrenaline at 7.7 milligram per kg body weight. For lignocaine in tumescent, it is 30 to 40 milligram per kg is safest. Peak plasma level is achieved roughly by 8 to 32 hours after the procedure. Metabolism of lignocaine, we all know, is cytochrome 450, cytochrome P450, 3A type 4, and anything which delays or which affects this enzyme delays the metabolism of local anesthetics and leads to toxicity. Toxic levels are way below the normal toxic levels of 6 milligram per liter of blood, but clinical signs usually come as early as 3 to 4 microgram per ml, which is circumoral numbness, 8 micrograms per ml of blood, tachycardia, tachypnea, confusion, disorientation, and visual disturbances. More than 8 micrograms, the patient can become unconscious and have seizures. At 10 to 20 micrograms, cardiorespiratory arrest can ensue. Now, these are basic guidelines. All these clinical features can come at any point of time and very rapidly can be converted into the next step. So that is predominantly the major drawback of this, and it calls for utter vigilance. Other local anesthetics which can be used is prilocaine, articaine, bupivacaine, and ropivacaine. There had been concerns of prilocaine use causing methylogomia, but various studies have not confirmed that there is any risk of methylhemoglobinemia with the use of prilocaine, and it can be safely used. Articaine, which is predominantly a local anesthetic used in dentistry, is also used, and because it is ester linked and metabolized by plasma esterases, the clearance is pretty fast. Bupivacaine has its cardiotoxic ability, so is not one of the preferred choice, and ropivacaine, because it's more cardiostable, is next preferred choice. Drugs which affect the cytochrome P450A3A4 are the common drugs used in anesthesia, like benzodiazepines, propofol, dexamethasone, methylprednisolone also, and various others. The list is too big. Now, what is the advantage of tumescent liposuction? It provides a complete regional anesthesia without the need for nerve block in the desired area or the operated area. The effect persists up to 24 hours, reducing the requirement of postoperative analgesia. The adrenaline reduces the blood loss level because of its vasoconstrictive properties. Minimal postoperative bruising is there. Rapid recovery is there. Smaller cannulas can be used to perform because of the turgor, because as the turgor is increased. Decrease anesthetic risk because intravenous and general anesthesia can be avoided. But it is not safe as it looks. What are the complications? In immediate time, it would be hypothermia, pulmonary fat embolism, thromboembolism, pulmonary edema, because large absorption of fluid can be absorbed from the third space, which leading to fluid overload. Local anesthesia systemic toxicity is a predominant feature. Hemorrhage, infection, and anesthesia-related complications become secondary. In short-term time, there will be wound infection, hematoma, seroma, edema, ecchymosis, paresthesia of the nerves in the surrounding areas. Skin necrosis can also ensue because of the paresthesia. Long-term issues, there can be contour deformity, hyperpigmentation, hypertrophic scarring, and lymphedema. And the long-term complications primarily give negative feedback, and the patients who have come for cosmetic reasons are really disheartened because of these complications. What are the contraindications? It should be avoided as a direct procedure in severe obesity. Individual simple liposuction as a weight loss procedure, it should be avoided. Body dysmorphic syndrome, tumescent liposuction should be avoided. Untreated psychiatric illness is a big no, and excessive scarring for previous surgery or previous injury is also a contraindication. There are various relative contraindications like moderate obesity, poor validity, hypertrophic or clot scarring, coagulation abnormalities, allergic to the medication, etc., etc. Coming on to the other procedure, the abdominoplasty. What exactly is abdominoplasty? Is also called as the tummy tuck. What we do in this is the subcutaneous tissue is raised above the rectus abdominis and dissected, and the flap is raised, and in the waistline it is stretched and stitched over there, creating a fresh umbilicus and pulling the whole area, as you can see in the depicted picture. It can obviously be clubbed with liposuction. Some authors say, and some procedure performers say, that increasing or clubbing these two procedures, liposuction and abdominoplasty, reduces the requirement to pull and decreases the mass, and better results are achieved, but at the cost of increased operating time and increased risk of possible complications such as fluid overload, hemorrhage, etc., etc. Intraoperatively, because it is tightening of the abdominal area, there can be a rise of airway pressure, and that suggests that the picration is too tight and it has to be reduced and the surgeon has to be warned. Post-operative, patient has to be shifted in the beach chair position, and they are advised to give compression garment at least 4 to 6 weeks. Coming on to the anesthesia part, pre-anesthesia checkup, history taking is equally important. Detailed history of comorbidities and OSA and sleep apnea and obesity pertaining whatever the previous speaker that has to be elicited. If the patient is coming for the liposuction or the abdominoplasty after massive weight loss, then we have to be very particular that the patient is weight stable. What does weight stable mean? That there has to be less than 1 to 2 pound loss of weight per month in the last 3 to 6 months. If it is more than this, then the patient is not considered that weight stable and should not be considered for any of these body contouring procedures. And we should wait for certain more time. History should also elicit The medication history. The patient usually are on OHAs, antihypertensive medications, MAO inhibitors, antidepressants for pertaining conditions for depression and etc. They can be on anticoagulants with history of deep vein thrombosis. They can be on antipsychotics. They can be on weight reduction medicines, which Dr. Indrani madam will take later on. They can be on herbal medicines, and they can be on dietary supplementations. These medications have huge implications as far as anesthesia is concerned. Most of the medications for weight reduction and herbal medications, they have. Hello?
फोन ही मेरा होल्ड कर दिया कर चलो होल्ड
weight reduction medications and herbal medicines have procoagulant effects, anticoagulant effects, and they can lead to increased bleeding. These patients might require psychiatric assessment because they have low self-esteem. They might be already on antipsychotics and antidepressants. So a psychiatric help should always be handy, which gives better results, better recovery in the post-operative period, and also there is a reduced requirement of analgesic supplements. Investigations, depending on the medical history, medications, and the clinical conditions, generally is CBC, serum electrolytes, blood glucose, liver and renal function test, chest X-ray, ECG, echo. Thyroid function test and coagulation profile may be handy because most of the patients have coagulation abnormality and may have increased risk of bleeding intraoperatively. Informed consent is very important, and the patient should know what they are undergoing and what are the possible effects. The plastic surgeon should make sure that he has explained everything in detail. Preoperative fasting guidelines are standard and nothing needs to be changed. Anxiolysis. Lorazepam is the drug of choice. If at all you feel that the patient needs anxiolysis apart from his antidepressant medications, then lorazepam has to be used. Midazolam, because it affects the cytochrome P450, should be avoided. Lorazepam is safer for that perspective. This is a flow chart. What investigation to advise, because consensus is moving from over investigation to investigating the patient with desire. So clinical presentations, symptoms and signs where you need electrocardiogram, clinical presentations and symptoms where you need chest X-rays, electrolyte glucose, liver function and renal function, clinical symptoms where you need them, and urine analysis similarly. What are the types of anesthesia we can use? So as in general, local with sedation, regional and general anesthesia all can be used, but with limitations. For example, local can be used for small volume liposuction, for smaller procedures, smaller duration, and areas which are not too vascular and too sensitive. But important is they require high amount of patient cooperation. They can be clubbed with sedation, and sedation of choice usually is fentanyl and dexmedetomidine. And again, this kind of sedation is used only for areas of smaller areas and small volume liposuction. Local and local with sedations cannot be used for other body contouring procedures like abdominoplasty, brachioplasty, breast augmentations, etc. Regional anesthesia can be used as a sole for abdominal procedures, liposuction in the abdominal area and abdominoplasties. Spinal being more as a predominant choice because small volume of local anesthetic is required, better motor relaxation is achieved, and prolonged duration of sensory blockade is there. Patient is awake, particularly in abdominoplasty. Spinal has an advantage that if it is the abdominoplasty plication is too tight, the patient can immediately say or complain about the difficulty in breathing, and the plication should be reduced. General anesthesia, of course, no contraindication per se, and is the desired and most commonly used modality of anesthesia. Drug of choices and remains the same as pertaining to other OSA and other clinical conditions. Regional anesthesia can be combined with general anesthesia, but for postoperative analgesia. Epidural has a drawback of large volume local anesthetics, and for liposuction with tumescent, it is a sheer contraindication because you exceed the toxic doses, even if you are using combination of local anesthetic agents. What are you supposed to monitor throughout the procedure? It is utmost important and not limited to the regular monitoring. NIBP, SpO2, CAPNO are the standard monitoring. But in case you have the gynoid population where NIBP will give erratic reading, IBP has to be considered. Surgical procedures in the areas of arm, like brachiopexy and all, NIBP cannot be attached. IV might be difficult, and central line and arterial line is the method of choice for monitoring in these patients. Most of the times, body contouring along with abdomen, thighs are also involved. So BP reading in the thighs are also erratic. Temperature has to be monitored, particularly in liposuctions, because the injected is cold most of the time. The temperature of the OT is cold. The fluid interaction, the transfusion of fluid is cold. Ventilation, if you're giving GA, causes loss of heat, and vasodilatation because of the anesthetic agents again causes loss of heat. Neuromuscular monitoring and BIS and entropy can be handy and can give you reduced drug requirement. Urine output is very important to be monitored, particularly when you are performing large volume liposuction or clubbing 2 or 3 procedures together. Airway pressure, if you're giving general anesthesia, it is important to measure airway pressure continuously during the abdominoplasty and plication procedures. Any rise of airway pressure more than 10 should be taken as an alarm and not allowed to be proceeded further. Flow volume loops, if you have good anesthesia machines, higher end workstations, it is important to monitor the flow volume loops. Apart from this, you are supposed to be ready for what all things. Always anticipate difficult airway and be ready with your difficult airway cart. Ramp position is important as highlighted by previous speakers. Bolsters and gel pads for positioning, because most of the procedures, when it comes to circumferential procedures, patients may be turned into prone, supine, lateral. All positions are to be taken care of, and bolsters and gel pads are very important to prevent the nerve injury, compression of soft tissues. You should be well aware with the treatment of local anesthesia systemic toxicity, and all antidotes should be, including the lipid emulsion, should be available. Always maintain normothermia, use warming blankets, use bear hugger warmers, cover the areas which are not in the surgical field, use warm fluids. Deep vein thrombosis prophylaxis has to be given to most of the patients, and defibrillator obviously has to be there. Positioning is important, prevent nerve injury, vascular and soft tissue compression, prevent joint dislocation while turning the patients, rise in airway pressure, particularly when the patients are put prone, compression of vessels leading to poor blood supply and blood return, poor venous return, particularly in the cranial areas and the lower abdominal areas. Dislodgement of airway is pretty common while positioning these patients, and regurgitation of gastric contents is very important. How do you calculate the intraoperative fluid requirement and the blood loss? While we are doing the liposuction with large volume liposuction with tumescent anesthesia, dermoclysis effect has to be taken into consideration. What liposuction does, it removes the 30% of the fluid which is administered. So 70% still remains in the body, which is in the third phase. The 700 ml of fluid per liter of injected is still retained in the body, and that has to be considered as an intravascular compartment because it will be absorbed and slowly converted into intravascular fluid. So what are the current recommendations? Restrict your intravascular fluid as to 0.1 to 0.25 ml of balanced crystalloid solutions per ml of aspirate. So when you calculate the aspirate, you know that per ml you are supposed to give 0.1 to 0.25 ml. If not, there are other parameters like fluid volume ratio. So whatever fluid is injected, whatever volume is injected, and whatever has come out. So in small volume liposuction, 1.8 factor can be used as IV intravascular fluid administration, but in large volume it has to be reduced to 1.2. Keep the residual volume in to the range of 110 ml per kg. Now, what is this residual volume? Residual volume is the volume of injected, total volume of injected coming out, going in, minus the total volume coming out. Now, the total volume coming out has to consider the volume of aspirate, the blood loss, as well as urine output. So if you keep that residual volume to 110 ml per kg, you can avoid fluid overload. How do we calculate blood loss? Blood loss calculation is very difficult, particularly in large volume liposuction. But the thumb rule is that if you're using the tumescent anesthesia, then it is restricted to 1% of per ml aspirate. If more, then you have to stop the surgery and reconsider all other conservation techniques and reschedule the surgery after some days. Perioperative antifibrinolytic agents are to be used, and if multiple procedures are done or clubbing of 2 or 3 procedures is done, then post-operative transfusion or hematinics should be considered depending on the HB and drain outputs. Post-operative pain relief. When you are using tumescent solution for liposuction, it reduces the requirement of post-operative pain relief for up to 24 hours. NSAIDs can be used but are avoided in case there is too much of bleeding or blood loss intraoperative period, or the drains have increased owing to their platelet affection. Opioids are to be avoided, particularly for their sedative effects, respiratory depression, and postoperative nausea, vomiting. Steroids are good and can be used for antiemetic as well as anti-inflammatory effects for pain relief. Regional blocks are pretty handy and should be promoted and used, provided you don't cross the toxic levels of the local anesthetics. Similarly, epidurals have the same concern, toxic doses of local anesthetic solution, but they come handy when you are not doing tumescent liposuction or large volume liposuction, but other body contouring procedures like abdominoplasty. Use of compressive garment reduces the bleeding and analgesic requirements. Positioning, abdominoplasty patients in postoperative period, if they are given V chairs, the reduction in analgesic requirement is pretty high. Coming on to what do we do at our institute? Yes, we practice tumescent liposuction with the vacuum assisted liposuctions. We don't have laser and the ultrasound machines, so we are using the high power vacuum assisted liposuction. We do perform abdominoplasty, and most of the times they are clubbed together, but the operating time is reduced to 2 to 3 hours. Whole body contouring and circumferential reduction of the volume is also performed in a single sitting. We also perform breast reconstruction and augmentation as well as reduction. When we perform large volume liposuctions or multiple procedures clubbed together, we don't do it under daycare. Daycare surgeries are exclusively for liposuctions for gynecomastia and etc. PAC we do as a standard protocol and history, not bypassing any of the things including the airway and comorbidities. Investigations we practice that usually we do a CBC for less than 40 years and no comorbidities. ECG more than 40 years along with CBC, and echo if other symptoms and other comorbidities come. We step up investigations as and when desired. General anesthesia with Prosil LMA with or without muscle relaxant, or general anesthesia with endotracheal tube is the commonest mode we practice. Post-operative nausea vomiting prophylaxis is invariably given to almost all patients in the form of dexamethasone and ondansetron. Sequential compression device and warming mattresses are always used for these patients to prevent deep vein thrombosis and hypothermia. Postoperative analgesia is multimodal in form of NSAIDs. We do give USG guided blocks. In case of abdominoplasty, we give TAB block, paravertebral block, and erector spinae block. We avoid postoperative opioids as much as we can. If at all we have to give, we use tramadol slow infusion. Our tumescent solution is most of the time ringer lactate solution 1 liter or sometimes normal saline added 2 cc 1:1000 adrenaline, which is total 1 gram, and we take care that it is always fresh, no discoloration in the adrenaline. 25 cc of 2% xylocard we are using in the solution. On top of this, we add 1500 international units of hyaluronidase, 10 milligram of triamcinolone acetate, which is the particulate steroid, and 500 milligrams of tranexamic acid we give in the injected. We take care that the solution, the infuser solution, is preferably pre-warmed at 37 degrees centigrade to prevent hypothermia. In nutshell, yes, anesthesia is challenge. Patients are high BMI, figure conscious, low quotient for dissatisfaction. Proper preoperative patient counseling and assessment is very important to prevent most of the postoperative complications. Massive weight loss leads to electrolyte metabolic abnormality and coagulopathy. So these patients should be dealt with carefully and investigated thoroughly before subjecting them to any of these procedures. Anticipate difficult intubation, remember the drug interaction, and stay to your toxic doses limitations throughout the procedure. Keep them in mind. Clubbing two or more procedures increases the chance of perioperative complications, and you should be very cautious in them. Avoid fluid overload as well as underload. Take care during position, and prophylaxis for deep vein thrombosis and post-op nausea and vomiting is of utmost importance. Say no to daycare procedures if you're performing large volume liposuctions, when you're clubbing multiple procedures, when the expected blood loss is more than 500 and operating time exceeds more than 6 hours. Do not discharge them even if they meet the discharge criteria on the same day. These are my references. Thank you so much.
Thank you, Dr. Ujjwal. That was a very lucid presentation and quite in detail. So we have a couple of questions by Dr. Indrani Madam, one of them. How much maximum local anesthesia have you used? That is probably for the tumescent anesthesia.
So 25 cc in 1 liter of 2% xylocard.
Okay.
So the injected is never more than 1 liter. We stop it at 1 liter. If you are performing more than 5 liters of liposuction, then we take care that the volume is distributed, the drugs are distributed into 2 volumes.
So I think there's another question from Madam. She asks, is GA with LMA ETT used also apart from tumescent anesthesia? So when you're giving tumescent, do you use apart from that even?
Sorry, I didn't get it.
So apart from tumescent anesthesia, is GA with LMA or ETT also used? So in the same patient you're using tumescent, do you also use LMA and ETT? That's what Madam's question.
Yeah. If it is a large volume liposuction where we are planning to go up to 4 liters, then the patients are not comfortable with the friction movement. They might not complain of pain, but they are not comfortable. So in those patients, we put Procil LMA, keep them sedated, secure the airway, and continue the procedure.
Okay, so I think the next question Madam was asking was this. So do patients tolerate long surgical time without sedation for liposuction? So that answers that probably long sedation, right? Yeah. One question from my side. So a couple of things I had wanted to ask, but you have already answered it about the IV fluids and the regional blocks. So one last question, prolonged duration of surgery, unplanned. So those go for your daycare procedures, right?
Against daycare procedures.
Again, no, they don't go for daycare, but on table you have decided, but then it goes prolonged, you admit them. That's how you go about it. And then do you catheterize all the cases or those which you are planned going for a long duration?
So when we club the procedures, when 2 or more procedures are performed, then we catheterize. Okay. Only liposuction, we don't catheterize.
Okay.
only abdominoplasties we don't catheterize. But when there are multiple procedures joining together, say for example, liposuctions at various places, which is large volume liposuctions, abdominoplasty, brachioplasty, thigh lift, gluteal lift, gluteal contour upliftment, if these are to be done, then we catheterize the patient.
Okay. There is one question from Falgu Darash. Says, can you please repeat the residual volume? That is probably regarding the IV fluids.
Yeah, so residual volume, it's a simple mathematics. Residual, whatever you have given and whatever has come out makes the residual component. So you have given injected as well as IV fluid, and whatever has come out is the suction or the aspirate, second the urine output, and third the blood loss. You don't consider insensible losses in them. So the previous one minus the second one is the residual volume. If you keep the residual volume to roughly up to 110 ml per kg, then you can avoid the fluid overload as well as underload.
Okay. So for the next question, what are the steps to be taken if raised airway pressure is noted after abdominoplasty?
Yeah, the first and most important is that the pipation has to be reduced. They have to increase the length of the graft. If they are not able to do that, then probably they have to do a second stage procedure, not make it too tight, allow it to grow for some period of time, and then do a second procedure. So that has to be explained to the patient pre-operatively and conveyed it to the patient post-operatively also.
Okay. So one question from Vishal Singla. He says, many patients going for liposuction and abdominoplasty are on keto diet with urine for ketone positive. So can we go ahead with the surgery or should we postpone? That is his question.
Yeah, so keto diet, if you have seen my chart, although it was for a brief, the urine analysis, we do it when these patients are there and ketones positive. They are likely to have acidosis, and if you are performing a shorter procedure, you can still go ahead, but take help of ABGs and correct their acidosis. There is no strict contraindications for not doing the procedure, as long as you consider the possible complications and you are in position to treat them.
Okay. I think covered most of the questions very well. So any other further questions, probably you can put in the chat box and you can further answer over the next session probably. So that was a good one. One last thing I wanted to tell is regarding last. So the center where these procedures are done, probably the doctors and the staff including should have the last kit, not only in the OT as well as in the post-op areas, with the infographics placed, and they should even have a drill periodically, because the staff also should be knowing very well regarding last call. So that is one addition I wanted to make. So thanks a lot. It was a very good one. Thank you. To conclude, I would just like to thank Indrani Madam, S.K. Sharma Sir and Naveen Sir for giving the opportunity. So over to you, Sonal.
Thank you, Chairperson. Excellent lecture, Dr. Ujjwal. I'm sorry that we may not be able to have the next lecture because Dr. Pandya is down with COVID and he's still recovering. So we are very sorry. We are unable to have his lecture, and we are wishing him a speedy recovery. We still have a few questions. I think so most of the questions to Dr. Ujjwal are answered by now. So Dr. Amla and Dr. Pandey, can Dr. Indrani ask whether these procedures can be done as daycare procedures, bariatric patients?
Actually, just if the patient is obese, it doesn't candidate for day.
Amla.
One figures that cutoff value is around BMI of 40, but there are certain other issues which we must take into consideration, whether the patient has other comorbidities or if he has significant OSA. Whether the degree of invasiveness of his surgical procedure also should be considered. Other logistic issues like whether he has a caregiver with him and how far he stays, all these factors must be taken into consider. But OSA, comorbidities and invasiveness of the surgery are the main three factors, and of course BMI when it is restricted to less than 40 kg per meter square. Another thing is, if his management after as an inpatient is not going to be different, if he were to get discharged, then also he can be discharged and the patient, the surgery can be carried out as a day case surgery. OSA comorbidities are the major deciding factors.
And instruction should be given even in the when he's going to home actually.
Yeah.
Are the NPO guidelines same for bariatric patients, morbidly obese patients as for normal patients? Is another question.
Yeah.
Yes, ma'am. It is the same in both the groups.
In fact, what we follow, when we are using that fluid, we give around 200 to 300 ml of fluid 2 hours prior to surgery, and that will reduce your fluid requirement during surgery, because then you are not required to calculate the starvation fluid which needs to be given over first 2 or 3 hours. So we do give clear fluid, just water, simple. We
Same
don't
as
give
in normal patients.
yeah. So it can be given same as normal patient.
What about short-acting muscle relaxant for intubation, which is the preferred one? I think
If you are expecting the intubation to be difficult, just because the patient is obese doesn't mean that the intubation is going to be difficult. So other criteria for difficult airway are not there. Then if you can ventilate the patient peacefully, you can, after giving propofol, you can very well go ahead with long acting muscle relaxant also. But if you are expecting difficult intubation, then it is better to go for scoline at the moment, because we don't have Sugamadex with us. So even though with rocuronium and suxamethonium, the intubating conditions are reached more or less, within 60 to 90 seconds, the offset after scoline is much early. So in absence of Sugamadex, and whenever you are expecting difficult airway, it is better to go ahead with scoline. Another thing is, just because the airway is simple to start with, because of repeated intubation attempts, a simple airway can turn into a difficult airway. So that factor also you must take into consideration.
what about the dose of succinyl choline in a 100 kg patient?
200 milligrams. It is
way
according to total body weight.
Yeah, 1.5 to. It is better to have a completely relaxed patient rather than struggling with your intubation.
But in case if the patient is already a known case of predicted difficult intubation, then I think better to go for fiber optic, awake fiber optic.
Yes, that is.
It will be safe.
So actually, what is your protocol of intubation? Regularly you do under general anesthesia, or preparing the patient airway for fiber optic intubation?
No, if the patient is it's a difficult intubation case, known case, then we go ahead with the fiber optic awake. We explain the patient, because I have seen that these patients are otherwise agitated.
Okay.
So if you explain well and explain everything step by step, then they are very cooperative.
Times actually I feel the problem is mask ventilation rather than intubation.
Has reduced the need for fiber optic intubation to a greater extent.
So I feel in morbidly obese patient, you may actually face more problems with mask ventilation, rather than a difficult intubation.
There's another question for Dr. Pandey. Is there any special anesthetic consideration for bariatric surgery patients?
There are mainly 2-3 considerations which commonly we face is airway and the ventilation and the hemodynamics, because once they are in the steep reverse Trendelenburg position, the hemodynamics are
How do you monitor the blood pressure on NIVP?
It's normally with NIVP, but many times NIVP is not properly measured because of the cuff size, or then we go for the invasive blood pressure monitoring. And there are some conical blood pressure cuff is also available, but we don't have that thing, in which they are saying there is some 10% difference of actual blood pressure. That can also be used.
Dr. Bhuvan, can I ask a question?
There is usually will be laparoscopic surgeries, and therefore there will be compound effect of increased IAP, the pneumoperitoneum, and on the splinting of diaphragm. So that can get compounded.
Yes.
Dr. Bhuvan?
Yes, sir.
Arterial line regularly, or what is this thing?
Not regularly, madam. If in case some cuff problem of the size of the arm is too big, and if the cuff is not fitting in that thing, then we go for the arterial.
Or the patient's comorbidities demand that.
Naveen Malhotra wanted to say something.
Dr. Bhuvan, my question to you is that post-bariatric surgery,
yes, sir.
Usually these patients have issues with regurgitation, and they are on some particular diet, more on liquids, and they are under the supervision of physiotherapist also, and doing excessive exercises also.
Yes.
So such a patient comes for a non-bariatric surgery after bariatric surgery. So what particular points we have to look into?
If the procedure is done, say, a few years back, then nothing is special actually. But
within 1 year,
then basically not too much of PEEP or something like that. But otherwise, there is no other precautions.
Any particular issues pertaining to aspiration prophylaxis and other things?
No, aspiration prophylaxis we give, but otherwise no other issues actually.
I think we can end the question answer session over here. And I now
can I ask one last question to Dr. Ujjwal? Dr. Ujjwal, for the liposuction part of it, since we have a lot of childhood obesity going on, how do you go about the children? What is the youngest age of the child you have done for liposuction? I just wanted to ask his experience.
Not in children, not less than 17 or 18. We have not done in children.
You're not done. It's not done. Thank you.
So basically, tumescent liposuction and liposuctions are contraindicated in morbid obese patients as a direct treatment of weight reduction. They are basically body contouring procedures. They should be promoted. Such patients who are demanding these procedures, they should be promoted for other modalities of weight reduction first, and then consider liposuction as an additional.
Now, to conclude, I would like to invite Dr. Indrani Hemant Kumar to give a vote of thanks. Madam is a professor and head of the Department of Anesthesia, KM Hospital, and she's also the president of Mumbai branch of Rsacp. Madam.
Madam, please unmute yourself.
Mute yourself, Madam Indrani.
Dear friends, I'm extremely sorry that we couldn't have Dr. Sunil Pandya for the obese parturient lecture. We're all eagerly waiting, but sometime later he has promised to give us the same lecture. And actually, to fill in his space, I wanted to give an offbeat lecture on over-the-counter drugs for morbid obesity. I have to respect your time, and we needed more time for interaction. So on behalf of Rsacp Mumbai branch, it's my pleasure it was definitely a pleasure for me to host this this webinar under this August banner. Let me start by thanking Dr. S.P. Sharma, President, and Dr. Naveen Malhotra, Secretary, for this opportunity. My sincere thanks to all the speakers and to all the chairpersons, and above all, my humble obeisance, and thanks to all of you who have logged in such large numbers for this webinar. And believe me, we will continue this tradition, and we will go ahead and give lively webinars in future. Thank you very much, and long live Rsacp.
Long live Rsacp.
Long live Rsacp.
Thank you. Thank you, Dr. Indrani. Thank you very much.
Thank you so
Thank
much,
you so
madam.
Thank you, Indrani.
And thanks to all speakers.
Thank you.
Thank you, sir.
Thank you, Dr.
Thank you.
Sharma.
Thank you, Indrani.